Hello, everybody, and welcome back. It's great to have more than 200 people on board. Super. And again, if you want to pose questions, do it through the Q&A. You can do it anonymously if you don't want to identify yourself. I have to introduce someone called Professor Robert Boy to give a talk on Nanopatch technology. I have a declaration of interest, which is that I work with them now 1 day a week as a medical officer. And these are slides that will also be presented at the PHAA meeting at the end of, well, in a day or two, actually. So I now need to tell Robert to share his screen. Do that, Robert. Okay, so this talk is about the hopefully needle-free future of vaccination generally. I'm going to concentrate, however, on the studies done against influenza with the Nanopatch. It's a tiny instrument, as you can see there. Now, Nanopatch is run by a group called Vaccus, based in Brisbane. It came out of the University of Queensland 10 years ago, and its current portfolio involves some pretty major collaborations in global health with the Bill and Melinda Gates Foundation, looking at cold chain independent needle-free approaches with Merck in a confidential collaboration, pandemic work with BARDA in the United States, with the United States government, and its own internal pipeline looking at prevention of flu and potentially even COVID. So that's the outline. It's a pretty straightforward and simple technology once it's applied to the skin using a spring, which is preloaded within the mechanism. It's sterile. You apply it, you press, you leave it on for just 10 seconds, and the cutaneous delivery goes into the upper dermis and lower epidermis. It's dried, so you minimize the use of the cold chain, as I said, and it even has the potential for self-administration. Where does it go? Well, the microneedles are more than 1,000 on a square centimetre. It goes at a predetermined speed of 20 meters per second. It's controlled and consistent in its skin penetration, and the danger signals that it elicits are enhanced by the local trauma that's induced. It's not painful, and that's one of the big sellers of the technology. There's a rapid release of antigen, and immediate innate alarm signals lead to antigen presenting cells coming into the skin and then going back to the lymph nodes. So we've especially done a study in the use of influenza vaccination using a standard seasonal influenza A, H1. And the study was done in young adults, 20 subjects per group, and looked at both safety and tolerability as primary objectives, with a placebo given intramuscularly. And the immune response was looked at 4 dose levels, 2.5, 5, 10, and 15 micrograms, compared to a standard dose of intramuscular, and at 2 sites of application on the forearm and the upper arm. And secondary measures looked at local skin responses via biopsy. Immunogenicity was a key outcome. And here's sort of a very brief summary of an impressive study where significantly higher antibody titers were achieved against influenza A, H1 Singapore. It's just been published last year. And both the 10 and the 15 microgram doses gave an earlier and higher response than the intramuscular, which is the third line down, and significantly different at that. Even using 1/6 of a dose, which is 2.5 micrograms, it was clear that a good immune response could be achieved and comparable to intramuscular. So potentially dramatically increasing the number of doses for the amount of antigen you have, and accelerating the uptake of a vaccine against influenza or potentially other pathogens too. So breaking down those results, you can see that even after one dose, there was good response. And two different approaches were taken to determining immunogenicity: microneutralization, a functional assay, and hemagglutination inhibition. And as you can see from this graph, excellent responses to the second dose, and even good responses to some first dose as well. So the adverse events were studied carefully too, because this was a phase 1 study, and no serious adverse events were noticed, which is great. Standard responses of some redness that lasted up to a few days, but nothing that led to people not wanting to have the vaccine again. So the erythema was just for a few days. So quite encouraging, both by local reactions and more systemic as well. Another really important point is the issue of temperature stability as it relates to the cold chain. And the studies done on stability at 40 degrees Celsius showed no change in the high density microarray patch by way of its potency. Whereas if you look at a standard quadrivalent vaccine, it doesn't perform as well, as you can see on this table in the graph. So thereby both the costs and the logistics should be improved. And already mass scale distribution is being set up. Good manufacturing processes are being followed. And as you can see on the right side, a magnification of what the array needles look like. And you can see the dry coating of antigen on the upper half of those microneedles. So just a minute or two on some very, very new development. It's not phase 1 yet, but there's hope that phase 1 use of the map can be started soon in regard to the spike protein of COVID-19. So a study's just been completed in the last couple of months in mice using 2 micrograms on days 0 and 21 intradermal presentation, and compared intradermal presentation of antigen compared with the high density microarray patch. And as well as presenting spike protein, some of the experiments involved using an adjuvant QS21, a saponin. If you examine the graph, you can see that in mice, excellent serum neutralizing antibody response against the vaccine strain was achieved, but also against variants, which is important for a virus that's mutating so fast. The unadjuvanted, without QS21 map, was as immunogenic after the second dose. But even one dose with an adjuvant looked impressive. And taking the study further to a functional level and to see whether the immunized mice were protected from challenge with COVID-19 and protected from dying, and you can see clearly here that they were. There was 50% survival in the unadjuvanted group after one dose, but 100% survival and protection from weight loss if it was adjuvanted. And the 2-dose group showed excellent survival as well, 100%, and protection from weight loss, severe clinical complication. And looking at both the lungs and the brain, there was no virus that got extended systemically to the rest of the body. So very encouraging result. It's only mice, and phase 1 in humans is planned ASAP. So just a practical note about how the device is put together. You can see the spring, you can see that they can nest against each other, and so the space occupation in the fridge is equivalent to needle and syringe. It's sterilized, gamma and gas sterilization can be done. the high density microarray patches within it. You peel off an alfoil and you apply it with one finger against someone's forearm, as I said already, so that you get a tactile piece of feedback that you've delivered the vaccine. So the manufacturing scale I've alluded to already is on the increase, and a new facility is being currently built on the north side of the river in Brisbane. So it's moving at a fast pace. So this talk, I hope, gives an introduction without going into a great deal of detail. It is designed, the patch, for simple and quick vaccination, potentially for people doing it for themselves, which in a pandemic could be terribly practical. There is potential for dose sparing. The stability looks impressive, at least 12 months at high temperature with a monovalent flu vaccine. The logistics are simplified. The scale up is happening right now. And so I hope that's clear, and I'll be very happy to field some questions later on after other people have spoken. This was a fill-in talk because we lost one of our speakers very recently, so forgive me if I'm technically challenged. So thank you very much. I now have the pleasure of not having to speak because I'm going to introduce Professor Stefan Gravenstein. I've known Stefan for quite some years now and admired his work tremendously, doing extraordinary clinical research in aged care facilities across many hundreds of facilities in the United States, and taking an approach which is highly scientific and highly practical at the same time by doing cluster randomization of whole facilities to one product or another, specifically against influenza, to control influenza cases and outbreaks in aged care facilities. And I'm so looking forward to Stefan's talk, and I hope he can share his screen better than I can share mine. Cheers.
Thank you so much for that kind introduction. I get to speak about influenza in the elderly, and with any luck, I'll give you some a mix of clinical and laboratory context. I do have funding, not just from our federal agencies, but also from Pfizer, Sanofi, and Seqirus. And some of the work that I'll be showing that we've done was funded by us, Sanofi and Seqirus. I'll talk about influenza and immunosenescence. We'll look also at some indirect effects of disease and vaccines to prevent those, and vaccine effectiveness sort of mixed together in a sequence that makes sense to me. So very briefly, the backdrop of this is as people get older, and in this graph, it begins at age 65 and up. You could start the graph at age 50 if you wanted, it really doesn't matter. But with age comes an increase in risk for bad outcomes with influenza. And this graph in yellow shows annual hospitalization rates from 79 to 2001 from 65 to greater than age 85 on the right. And the red bar shows mortality in rates per 100,000 population. So you can see this is very much age related. Age is more complicated than just getting older. There's other things that happen. So you have to understand that part of this hospitalization risk is not just because of flu itself, but in people who have flu, if they have cardiovascular disease, chronic metabolic disease, chronic lung disease, and a host of other things, their risk is also higher. And you can see that those risks aren't exactly linear with age. With cardiovascular disease, it does go up slowly, but with chronic metabolic disease, chronic lung disease, there's a decline after age 75 in part because the people don't survive to have those outcomes later on. So influenza vaccine is effective in older adults. And I think any of the vaccines that are currently on the market in Australia, we could argue are effective. Globally, flu causes some 3 to 5 million severe illnesses and 250,000 to 500,000 deaths each year. From a national study from Britain, there was a retrospective observational cohort for the period of 2000 to 2009. And they did propensity matching for a variety of things to try to understand what the benefit was of vaccine. In this, they had 1.8 million persons seasons of observations, 250,000 influenza vaccines targeting at risk. Most of those were that, with 69% uptake by age 65 and older, so about 180,000 vaccinations. They used laboratory confirmation by RT-PCR in a subset. There's 3,200 in that. And in this, they demonstrated over the course of these 9 years, 57% overall vaccine efficacy, only 18% in the group that was 65 and older against laboratory confirmed illness, a 16% reduction in primary care consultations for influenza-like illness, 19% for reducing pneumonia and influenza hospitalizations, and 38% effective in reducing mortality to influenza pneumonia. So those numbers, if you keep them in the back of your mind, you'll see are similar to the additional reduction you get when you add an enhanced vaccine. Europe did a 9-country study with where A, H3N2, and B were in co-circulation from 2017 to 2018. And this was a test negative design for adults 65 and older. And they were looking at people who had an acute respiratory infection with RT-PCR confirmed flu. So there was almost 3,500 people in this cohort, of which 376 had AH3N2 and 928 had influenza B, with just over 2,000 controls. And the vaccine efficacy here is estimated around 24% in the 65 to 79-year-olds, 14% in the over 80-year-olds, but still some effectiveness both in the younger and the older group, and also against influenza, even though the influenza B was a mismatch that year. So we did a study that we published a decade ago, and this is from people living in aged care homes. We call those nursing homes in the US. And what we have in this graph are percent of subjects who had a mild elevation of temperature. We're calling it fever, by definition as 37.2. And there are 3 groups here. The unvaccinated group here, and these are all laboratory confirmed flu, by the way, is the blue line. And this is the percent of subjects in this blue group, which was just over 500 volunteers who developed flu. And then we follow the course of the proportion that had a fever in excess of 37.2 over time. And you can see this lag in clearing of that elevated temperature could take up to a few weeks. The green line is the good match vaccine, and the pink line is the bad match vaccine. And you can see that even with the bad match vaccine, you had a substantial reduction in the proportion who had this elevation in temperature. And in addition to that, much more rapid clearing of that elevated temperature. So the point here is fever to me is a proxy for underlying inflammation and clearing that inflammation. Now, you may wonder why the good match doesn't perform quite as well as the bad match vaccine, and that's just about how we present the data. So the attack rate for influenza in no vaccine was around 22%. For the bad match vaccine, it was around 18%, and for the good match, it was just over 5%. So these are the few breakthrough illnesses where the vaccine failed to protect these old, frail individuals. So now I want to take that message about elevated temperature and park it in the domain of inflammation. So this is a paper published by Smith back in 2004. And what's interesting about this, if you look at this paper, he has reports on individuals that have first ever heart attacks and first ever strokes, and then other tables, which I won't show, with not first heart attacks and strokes. And the numbers are quite similar. I've sort of summarized them here. With systemic respiratory tract infection, this group here, in the first 2 weeks after this respiratory tract infection, the risk of having a first ever MI is increased almost 4-fold. And there's a tail on this risk that lags out to 3 months. If they had a bladder infection, it was elevated about 1.6-fold in those first 2 weeks. And again, there's a tail on it that is still present out 2 or 3 months. Likewise, for first ever stroke, you can see it's about a 2-fold increase in risk with a tail that goes out to 3 months, and bladder infection. So I think of each of these as proxies for inflammation, and inflammation driving the coagulation cascade, where you might plug up a coronary or cerebrovascular cerebral vessel. So other forms of inflammation. So if you look at specifically with pneumonia, followed by cardiovascular events, this report by Corrales Medina, a quarter of adults admitted to hospital with pneumonia developed a major acute cardiac complication during the hospital stay, which is associated with a 60% increase in short-term mortality. A separate study done by Violi from 2017 and 1,200 people who had community-acquired pneumonia hospitalizations followed for 30 days. A third of them had a cardiovascular event in that month. A quarter of those were heart failure, 9% were atrial fibrillation, and 8% were heart attacks. So with it, there was also a roughly 3 to 4-fold increase in mortality compared to those without cardiovascular events. So I was making the point about pneumonia as an infection, and I said UTI before that. You know I'm talking about flu, right? So I just want to make one more inflammatory moment. This is with shingles. And Kim reported in 2017, the risk of a heart attack following shingles is about 1.6, so a 60% increase. And that risk goes up with age. And a stroke is about 1.3, and that actually decreases with age. A separate paper also detailed this risk for strokes and heart attack, and that this has a tail on it at least 3 months, but maybe even out within a year, depending on how you draw your cutoff. So Jeffrey Kwong in 2018 published in the New England Journal a test where he was looking at individuals that in the Toronto system had tested positive for respiratory viruses. So there were 280,000 of these respiratory virus tests, 19,000 of those were flu. 500 of those with flu were hospitalized with a heart attack. Of these, 332 were unique patients and had flu in the week before the heart attack. So the risk for an acute myocardial infarction, this is the incidence ratio, is 6-fold higher in the week after flu. You should note that, remember, I'm saying this is about inflammation from infection. This is also increased following respiratory syncytial virus infections and other viruses by about 3-fold. So that's down here on the right, 3.5 for RSV. Other than RSV, 2.8 and so forth. So when I teach my house staff about this, I have devised this image of if you have inflammation and when you have no inflammation, your markers of inflammation are on the floor, low CRP, interleukin-1, 6, TNF alpha. And just by getting age, these markers start going up and your inflammation overall goes up some and your propensity to clot goes up. You add to that obesity, diabetes, arthritis, and vascular disease, dementia, and these numbers go up even higher. So these are climbing and they move you toward a risk for having a vascular event. And you throw on top of that an acute infection like influenza, RSV, community-acquired pneumonia, shingles, bladder infection, pressure sores, and it shoots way up. And it's highest in the time right after the infection, and then gradually trails off over a period of months. And in older people, it takes longer to go back to normal. So the model here is on the left-hand side, one of these infections. Then you get acute inflammation with reduced protein CRS and a host of other things, including cytokines, which give you many of the symptoms, thrombogenesis, and then a heart attack. So to make this as a final point here, this is a graph on the vertical axis is hospitalization for acute heart attack and COVID-19 per 100,000 person weeks. And the yellow line is what happened in 2019 in Northern California in the Kaiser Permanente system. And you can see they were relatively stable in the period from January through April. Come 2020, you can see this is the red line for 2020, when they had their first reported death from COVID-19, this started dropping down as people went into isolation, and that prevented the spread of all sorts of respiratory viruses, not just COVID. And you can see that as people stopped getting respiratory tract infections, the risk for having heart attacks or being hospitalized for heart attacks went way down. To really put a point on this, look what happens with flu. So this is hospitalizations with influenza, January 1st. And then as people started isolating, this is a different scale up here, okay? You can see flu events plummeted, helping draw down these AMIs, but so did RSV and other events. Even as COVID was causing cardiac events, the reduction from all these other inflammatory infections drew it down further. So Raina McIntyre, whom you may know, published this wonderful paper on the benefit of vaccine in reducing these cardiac events. And the way she presented this is actually pretty cool. So your risk reduction from stopping smoking is 32 to 43%. From statins is maybe 20 to 30%. From antihypertensives, these are drugs you take every day, 17 to 25%. But flu vaccine actually reduces it by 15 to 45%. So you only have to get that once a year to get the benefit that you get from having to quit smoking all year long. If flu can cause heart attacks, it probably does other things too. Again, in our aged care facilities, there's some 2,000 in this particular study that we published back in 2012. We looked at functional status over time. And what you can see here is up is bad, down is good. Red is mortality in the cities where these 2,000 facilities were. So we mapped these across 122 cities in the US. And this is the blue line is rate of functional decline. So up is bad. And you can see that functional decline happens in lockstep with severe flu seasons when the mortality is highest every season, year in, year out. And this period was from 99 to 2005. So what's causing this? And I would tell you that I think these are things that are probably not coded properly, where they have mini strokes or just don't fully recover and have functional loss. Now, why do these older folks not respond so well to these vaccines? You saw from the younger adults, as you got into your 80s, you got a 50% or so reduction in vaccine efficacy. And here's a study that makes this point. A review of 31 vaccine antibody response studies conducted from 86 to 2002. And in general, 65 and older had significantly lower antibody response to vaccination than younger adults. And this is to all the flu antigens. And they were typically half to a quarter of what they were in their younger counterparts, both by seroconversion and by other measures of seroprotection, like fourfold rises. So basically, this concluded that we need more immunogenic vaccines. Here's a graphic of this kind of observation. And this is supposed to be vaccine effectiveness, but you could have substituted here a different axis and done antibody and seen a different thing. And you can see in the older group, much less effective than in the younger group. So this is in part because of immune senescence. And as you age, your immunity is isn't as good, and it's more permissive for infection, including pneumonia and severe infections that can result in hospitalizations. It also impairs vaccine response. So the protection you get from vaccines isn't as good as when you're younger. This relates largely to changes in T cells, the subsets, and the cytokine production. And these profiles affect the magnitude, quality, and persistence of antibody. It slows recovery from infection, and it changes the symptom presentation with age. So if your interleukin-6 doesn't kick up as much, you don't get as much fever. And that doesn't mean you're less sick. It just means that the immune system, which gives you many of the systemic symptoms of flu, isn't kicking out the cytokines that allow you to feel that. So the summary of this section is that immune senescence conflates with underlying inflammation and multimorbidity in nursing homes to drive clinical and cost outcomes. You get reduced vaccine response and increased consequences for vascular outcomes, and poorly conceived vaccine and influenza prevention and control programs. So although these vaccines really show quite a bit of efficacy, if you have a better vaccine, maybe you can reduce that risk further. So here we answer that question. In 2014, there was a large randomized controlled trial with 32,000 volunteers at 126 centers with an intent to treat design conducted from 2011 to 13, where they gave a quadruple dose or high dose vaccine, and they got a relative efficacy compared to the regular vaccine of 24% additional improvement. And for hospitalization with influenza-like illness, roughly a 30% reduction. We did a study that was done quite differently, and this study was done in what we call a cluster randomized design. So in this case, we took these nursing homes. So this is nursing homes that we recruited were housing 92,000 residents in October of 2013. We were only interested in those over 65, so that's 76,000, and those who were there permanent. That leaves us with 53,000. And then we had two ways to analyze this. This is the full sample where we look at quality measures that are published by the nursing homes in a federal register, or the fee for service, which is you can get from information from the insurance companies that provide fee for service coverage. And that is our analytic sample of about 19,000 residents that were long stay over the age of 65 in each of these groups. And the short version of this, we had about a little over an 8% reduction in all-cause hospitalization, a little over 12% reduction in all-cause respiratory hospitalization, and a little over 17% reduction in all-cause pneumonia and influenza hospitalization. So the advantages of those first categories, like for example, all-cause hospitalizations, is when somebody doesn't present with symptoms of flu, but with a heart attack, you can find them in those other buckets. So you have a better way to account for them. So this is a graphic that shows this. All-cause hospitalizations here are roughly 300 fewer between the two groups of 3,500 versus 3,800 hospitalizations. And if you see this 300 person difference, 60 of those were pneumonia in the first position for diagnosis, just under 100 any respiratory condition, which includes pneumonia, not including respiratory conditions. If they had a first diagnosis of heart attack, heart failure, AFib, that's about 190. So you add these two together and actually you come up with this whole difference. So that's, we think, accounts for much of the difference in those two groups. And if you looked at cost over time, this is weekly, these are daily expenditures for these residents. And you can see that it's $400 for the high dose vaccine, the red line. You may not be able to see that it's red. The lower line here for most of the way. And the blue line, which is the one on top, while it's green, there's cost benefit for the high dose. Red, standard dose has cost benefit. But overall, this came out to about just over $540 after you paid for a vaccine difference in net insurance claims and costs. So this isn't quality, this is actually total healthcare cost because we can measure that. There's another vaccine out there, and you'll be familiar with this one because it's available in Australia. It's with MF59 adjuvanted flu vaccine for elderly. It's been available in Europe since '97, licensed in 2015 for 65 years and older. In the US now almost 200 million doses. And they use an oil emulsion of squalene from sharks to create this adjuvant to improve the vaccine response. It improves cross-reactivity. There's non-randomized controlled trial evidence of reduced hospitalization risk in elderly, large cohort studies, 25% reduction over 3 seasons and 80% protected versus 57 compared to standard dose in a long-term care population. These are not randomized controlled trials, so it's not the highest quality of evidence, but they're actually pretty well done. And one of your own, Van Bunder, was one of the authors of these studies. We did a similar study to the high dose study, cluster randomized. We published this last year. And this is a cluster randomized trial in 830, it should say 23 nursing homes, not 32, in a essentially identical design to the high dose vaccine. And I can see the formatting is weird here. So again, we had about 90,000 individuals in these facilities. And the group that was in the analytic sample is 25,000 in each group, roughly, adjuvanted versus regular vaccine. And the high level result is we had about a 6% reduction in all-cause hospitalization, didn't reach significance, but 9% for respiratory illness. Compare that to 8% and 12%. And PNI was about 21%. That was about 17% for the high dose. So similar results with this exception of respiratory illness. And we think that's a change, migration and coding over time for sepsis and other things. We actually saw reductions in UTI and sepsis in these nursing homes favoring the adjuvanted vaccine. And we think that's because when people come in, they think UTI first and don't always do due diligence, but we can't prove it. At any rate, the expected result for PNI and all-cause hospitalization, which was our primary outcome, held up. We did a subsequent retrospective look at this for outbreaks. So nursing homes got to tell us, and there's 777 of those that did, whether they had an influenza outbreak and whether or not it was laboratory confirmed influenza. 17% relative reduction, 133 in the ATIV facilities, 162 in the regular facilities. When you adjust for other factors, it's about a 20% adjusted reduction. So about a 20% overall reduction. So the summary here is aging and multimorbidity increase risk for influenza complications. Influenza is much more than just a respiratory disease in older adults. We need to do better at vaccinating everybody that's 65 and older, good match or not, every year, regardless of what vaccine you have. And if you have an enhanced vaccine, you may get extra mileage to keeping them safe. These more immunogenic vaccines can offer better protection. And that's the end of my presentation. And I thank Dr. Bowie and her group. We'll save questions for later.
Fantastic. Thanks, Stefan. Yeah, we're going to go to our next talk, and we're going to have questions for all the speakers after the third talk. Michael Murray is the head of geriatric medicine at Boston Health, and he's the president of the National Aging Research Institute. So he's just the right person to talk about aged care and the health of older people in institutions in Australia. So Michael, over to you, and looking forward to your talk very much.
Thank you very much for the privilege. I've really enjoyed the previous two talks, and quite frankly, I've learned so much. I've got my money's worth, well and truly. I'm the light relief between the intellectual content, and much of what I'm going to say is probably publicly available. I sit on a number of committees. What I'm presenting is my opinion. It's not current government policy. I'm going to briefly cover immunisation rates across a range of groups. We're going to look at the issues around inconsistency of messaging and problems with messaging and how that's affecting my belief is how it's affecting the outcomes. And we're talking about the vexed question of encouragement or mandated vaccination and where to from here. People will well know that the Victorian Wave 2 gave us some excellent information as to vulnerability in residential aged care. And there was lots of reasons for that vulnerability, as I've discussed at a previous meeting. Some related to delayed use of PPE, social distancing, some related to the way in which we staff and the presence of staff from a socioeconomic group that was very likely to be exposed to other risks, whether it be abattoirs, quarantine, etc. And the tendency for people to work across multiple facilities in order to make a living wage. We also know on that basis of where we're most vulnerable, and there is absolutely no doubt, and this was seen again in the third wave, which was obviously very tiny by comparison, Victoria to the second, that our west and our northwest is the most vulnerable area in Melbourne. We're aware that there's been a huge focus on immunisation rates, and by world standards, we've in fact done exceptionally well and are doing exceptionally well. We're currently got to all but about 34 facilities, and many have had the first dose, and quite a number have had doses 1 and 2. We're anticipating, on the basis of what's going on now, that will be completed by the end of July in terms of the vaccination rollout. About 15% are on average, about 15% of residents are electing not to be vaccinated. And there's a range of reasons in our experience of why that occurs. Most is choice, whether it's the choice of the individual or their family, and we're noticing that on quite a number of occasions, there's hesitancy or reluctance to vaccinate on the part of their family. Some are in an active palliative pathway, and there's been some recommendations that when people are expected to be passing away in the next weeks, that a vaccination may not be in their best interest, simply because any issue of side effects, which are minimal, to be honest, in the old and particularly frail, were thought to be best to be avoided. We do have nevertheless a significant range. We've got a mandatory reporting as of mid-June of staff vaccination. Now, I would have said that 33% have had dose 1. The Age I noticed on Sunday said it's 67% have not been vaccinated. So it's a bit like is the glass half full or half empty? We do have a targeted rollout to the highest risk LGAs. So unlike the vaccine rollout, where we were looking to encourage vaccination first in the West and in the Northwest, and we used a sort of a scattered gun or randomization approach, on this subsequent event, we've actually been far more focused. In terms of adverse events, people are well aware, and this was data, I think, presented back in 2017, that adverse events in the elderly are poorly reported. And that's obviously for a number of reasons. But what came out of this study in the MJA was the formation or the development of the active surveillance with VICSIS, the Victorian Specialist Immunisation Service, focusing on vaccination surveillance issues, because we all came to realise that in residential aged care, a phone survey system was clearly not going to be helpful or appropriate in this group of individuals. People will well understand that in a frail, very elderly group of residents, it's often very difficult to determine whether or not a post-vaccine or supposedly post-vaccine event is related to the vaccine or other issues, particularly given the significant attrition rate in residential aged care. And in any group of 270-odd thousand people, there'll be a number of people passing in the anticipated weeks, let alone post-vaccination. Nevertheless, there's been a low rate of reporting of issues, even though we've actually followed up 8,000 post-dose ones and 5,000 post-dose twos. People have been surveyed in residential care in Victoria. So I've actually had or attempted to have a deep dive in this group, and we've had a look through the process I've outlined, looking at any deaths or serious events in that's potentially temporally related to vaccination. In almost all cases, there's been general willingness on behalf of the treating clinician to ascribe what we're seeing to anticipated deterioration already evident in the particular resident. We've looked at some minimal number of cases, but we've not really found any loaded gun or smoking gun. So what are the emerging issues? Well, we're very clearly aware, and there's been much debate, and there's been much strong opinion in the media that mandatory vaccination should be required. And it seems to have been very much around a situation rather than risk-based assessment. And people are well aware that up until last week, only Italy had mandated vaccination for staff in residential care, and the current the WHO recommendation did not at this stage support mandatory vaccination. That's in terms of staff. People are aware that the staffing profiles in residential care or in community-based equivalent with aged care packages is significantly older, and it's more akin to the subacute setting within public health. And it's several years, 10 or so years older than in acute health, with the average age in residential care being around 46, in community-based equivalent about 52, and similarly about 47 or so in subacute care. The issue has become somewhat less polarizing with the recent move for AstraZeneca recommendation from 50 to 60 years. So whilst there are some staff that are older than 60 years, understandably, the number is much less. There's also been major issues, as people are aware, about access and availability, and people are well aware that the largest quantity of non-AZ vaccine is really only available in the last quarter of this year. This has particular relevance in my own experience in Victoria, where I do some rural work. It's significant in that there's a 2-hour trip from Alexandra, which is a small to medium-sized town in central Victoria, to a local vaccination hub, which puts it, certainly makes it far more difficult for staff compared to metropolitan And of course, in rural communities or remote communities, that's clearly magnified. If you've got a problem in a state the size of Victoria, then any larger state would clearly be significantly greater. People are well aware, and we've just seen the great data around influenza vaccination. People are well aware that there's been a significant proportion of professional health staff that have been reluctant in the past to vaccinate. And this has confused lots of people who have a significant role in public health as to why this is the case. There's no doubt that with some degree of bewilderment, not just related to the fact that some staff, e.g. non-clinical hospital staff, are on site and therefore it's very convenient, versus some staff like nursing staff who there's a significant number who are on a rotational workforce. But there's a significant difference in our non-clinical staff vaccination rate versus our nursing staff vaccination rate. There's also some problem in Australia, and people are well aware of inconsistent public health practice in terms of staff and mandatory vaccination. It varies significantly with jurisdiction, and it can vary over time, such as Victoria did have mandated vaccination, which were relaxed. And the major reason for relaxation was major issues with staffing. And this really leads us into the second problem of what would be an effect, what would happen if we mandated vaccination for professional and non-professional staff in residential or home-based care. And there's some current evidence from some studies carried out by some unions that there would be a significant depletion of workforce, perhaps surprisingly amongst professional workforce, if there was mandated vaccination in residential care. Now, perhaps to some people this would not seem to be a major issue. However, for people working in public health or residential care, the loss of 15 to 30% of staff would be catastrophic. And indeed, the loss of 15% of staff in public health, acute or subacute, would also be catastrophic, given the current problems we face in most jurisdictions. So there's major problems in residential care. And of course, in residential care, you don't have options that you would have in public, where you could perhaps redeploy staff into some non-clinical areas or move people around during an influenza season if such a thing really continued to exist. Because there's simply in residential care, remembering that the average size facility or the median size facility in Australia is somewhere between 60 and 80 residents. So it's a very small facility. And there's on average 1.5 staff members per resident. So you're talking about quite small facilities. And whilst there's been a tendency to move to group provider groups, and that's certainly continued over the last 10 or 15 years, still many facilities are very small and they're key person dependent. What are the contributing factors? And we don't really fully understand all of them. I think there's perhaps one of my big bugbears is there's divisive media reporting, and this is a personal opinion and doesn't represent anybody I work with or for. However, I think what I put down as the snide and condescending editorial comment, which tends to be thrown out as the throwaway line at the end of a news segment, and let me be honest, I mostly tend to watch the national news, the ABC type news. It's, I think, quite detrimental, and certainly amongst my colleagues, the geriatricians, there's been ongoing concern at the negativity that is regularly shown. I would admit that there has been some recent improvement. Nevertheless, there's been a rise in the naysayer and the armchair experts, and we've never had such a powerful retrospectoscope looking at what we could have or should have done in the past. I don't think there's any doubt amongst any of us that there's been substantial errors made or opportunities lost. But I think that the vehemency and the clamouring of the experts has been a little out of hand, and I certainly watched the ABC only as recently as last night, talking about what we should have done several to 18 months ago. And given that I was there at the time, it seems to be slightly incredulous. We didn't hear anybody promoting such ideas at that time when we're all in such desperate straits. It's perhaps no surprise to me and perhaps to anyone else that trust in a whole lot of experts, whether it be politicians, unfortunately, or journalists and media, is relatively low. The good side is that doctors, nurses, health professionals, and academics remain well supported. It's also fairly evident that we have a very reactive policy environment, and there's little doubt that this has contributed to our disharmony and our poor focus across jurisdictions. And the problem we've had, and I think Victoria and New South Wales are great examples of challenge, and it's very evident to me and probably most of us that politicians have well recognised the association of strength or apparent strength with benefit of the ballot box, and therefore people are being very jurisdictional. What's happening in vaccination amongst residents? Well, as I said, the majority of residents are electing to be vaccinated. It does appear to be better where we hit the facilities with as much information as is possible. Nevertheless, there's a significant range that we've seen. Worse early on, better with the more recent outbreaks, ranging between as low as 45% in some called communities, up to 98% in some facilities where we've actually had a bit of a blitz on support to the general practitioners and to the facility. We've certainly had some challenges with accessible, available information in some called communities. There's lots of work being done, some work around opinion leaders, etc., which has made a difference. And certainly people have been making a lot more information more readily available. As I said, there's been a significant rate of family next of kin reluctance, which perhaps represents their opinion rather than the resident. And it's not always paralleling that of influenza, interestingly enough. But there's been a lack of information that makes it a little bit hard to know, other than we've had a lot more requests for additional sweeps of vaccination to those facilities where residents had not been vaccinated early on, even though it had been offered. So I think what we're seeing now is that there's been a number of facilities being revisited, a number of people re-evaluating their desire to be vaccinated. There has been some cases of treating clinician discouragement, and where we've had a couple of cases with particularly in the cold community, with a reluctant clinician, we see plummeting rates. It's also my personal view, and I've got a conflict of interest, although not personal, around the modelling of a medical director type function in residential care. As people are aware, there's much of Europe and America have some coordination function in residential care, which a fee-for-service really doesn't adequately provide. And whether you call it a medical director model or a leadership model, clearly this is problematic in residential care, and its lack has probably been very notable in wave 2 of our outbreak, where, as I presented before, general practice was really unable generally to provide as an effective clinical service as most would have wanted. We've also got problems, practical problems, which we're still working through around resident admission rates. So Victoria is divided up into hubs, multi-tertiary hospitals per hub, somewhere between 2 and 4. And most hubs have 50 to 100 residents discharged, or people discharged to residential care on a weekly basis. So there's a rapid dilution effect of unvaccinated people, and we're really only starting to come to grips with what to do with the unvaccinated people being admitted to residential care. But given that there's a significant turnover, over a not too great period, we're going to see the number of people vaccinated in residential care start to significantly drop. We've also got problems about how we're going to manage residents and visitors in terms of mandatory vaccination. It's probably likely that there's political will to at least signpost and eventually move to mandatory vaccination in some settings. I don't think it's going to be risk-based. Nevertheless, and it's probably going to be situationally based, which is a bit illogical, but nevertheless, it's the likely reality. It's a bit hard to understand in the sense that you can work in acute hospitals and not be vaccinated, but you work in residential care with a similar group of vulnerable residents, and vaccination will become mandated. It's difficult from a resident perspective to ever think that we're going to likely have mandatory vaccination for a resident. We've got some practical problems, but apart from that, we've got an existing right of tenure, which is written into the aged care legislation, such that people have a right to accommodation and care. There would be a possibility of actually mandating vaccination for future residents. So that could be written into an Aged Care Act. Whether or not there's the political will to do so is a bit unclear. Nevertheless, it's clear that there's a risk to others, and as we're working our way through the Greek alphabet, and goodness knows what happens when we get to the bit that I can't pronounce. But there's certainly future variants are becoming an increasing concern, and therefore, with the number of people being vaccinated, with reluctance among staff, and more variants as the number of people worldwide who are COVID positive provide opportunities for additional variants to be created. It's certainly likely in my mind that we'll be facing this problem for years to come. Nevertheless, that even if we wanted to mandate vaccination, I don't think it's likely that this could easily be achieved in the Australian context till at least the first quarter of next year. So where to from here? So I suppose the question is herd immunity achievable in residential aged care? And I think given that the average resident stay in residential care is less than 3 years, and the staff turnover historically has been up to 18% per year, it provides a number of unique challenges. It's also even as or more difficult to figure out how we're going to protect people as we move increasingly to home-based care. So on the basis of the Aged Care Royal Commission, there was a significant hurry up to the government to release more home-based care packages. But of course, this has some practical problems around vaccination of providers. As we move towards extended support, it's perhaps in some ways easier if we have InReach as being recommended in the Aged Care Royal Commission, and if we move to embedded GP sessions or a medical director type limited model. And it might well be that if we could develop a maturing strategic approach, maybe that's a forlorn hope in the current climate, that I think is the only way we're going to be able to effectively manage residential care in high-risk vulnerable groups. Thank you very much.
Michael, that was fantastic. We've had the best expertise from Australia and the US all at the same time. There's a lot to unpack and discuss a bit further, but while you're having a look at the Q&A, Michael, just give you a chance to see what people have been asking. I'll turn first to Stefan and ask for his opinion about mandatory vaccination in the various settings, the residents, the workers, the visitors, how that works in the United States and what works well and what could be better.
I'm tempted to say it's like the Wild West here, depending on where you go. But in the there was a large lawsuit that came up against Methodist Hospital in Houston, where they decided to mandate vaccines, and that went to court, and the hospital won. Some 200 and some workers were threatened with the loss of their jobs if they didn't get vaccinated over the weekend, and most of them actually were fired out of a workforce of over 20,000. So the fear of having attrition of those workers wouldn't be as much of a concern if they had no place else to go, because every place was mandating vaccine for the healthcare workers. In our nursing homes, exactly the same debates have been happening as you've discussed. We have the unions who are trying to defend the rights of workers to say that they have an individual right against vaccination. But those facilities that have actually gone to mandating the vaccine, usually with new hires rather than existing employees for flu vaccine, have not really lost the workforce that they were afraid of losing. But that has been the main concern, is that suddenly they have a flight of healthcare workers. The hospitals is the first place where that's been happening here for flu vaccine. The Methodist Hospital example was with COVID vaccine, just in the news in the last few weeks.
Michael, would you like to respond to that and expand from your point of view?
The challenge in the Australian context is that we do have places for people to go, and already hospitals are actively targeting residential care professional staff to be transitioned into acute care. Much of acute care is desperately short of nursing staff, and there is a problem with our pipeline, and we're also become very dependent for clinical staff on an influx of overseas trained staff. So there's not a facility that I'm aware of, not a major health service, that doesn't run short every single day of the week. And therefore, people are actually actively recruiting, and people get paid better in acute care. So this is a really big practical problem. It might be you only lose 10% or 15% of your staff. Maybe it's not as bad as some people suggest. Nevertheless, these people are irreplaceable, and therein lies the problem. We've already got a very itinerant staff who we pay less, and in spite of people's talking about improving the pay rates, there really has been little move to improving pay rates. So we've had about 17 inquiries. When I was the chief clinical advisor, I got a whole wheel-on trolley of reports. So this is nothing new, but we actually haven't done nearly enough to make a difference. So I think it's a really big challenge, and we strongly need bipartisan support and support of unions. We need to find ways of supporting people to be vaccinated, because I think mandating is really the last resort, and it's really just not good public policy if we mandate vaccination in residential care, but everywhere else we look after a similar group of people in the disability context or the forensic context or the subacute context. We don't mandate it. It doesn't make an awful lot of sense to me from a policy perspective.
The example that Stefan gave resulted in only a 1% attrition rate if it was 200 out of 20,000. Is there it's a completely perplexing problem of how to get adequate numbers and adequately trained professional staff in aged care. Michael, you just raised the issue of not wanting to have inconsistency with disability care and the like. Should it not be mandated for all institutional care settings?
Well, I think it makes very good sense that you do a risk assessment. And I think a risk assessment should include front-facing staff where it's likely to become mandated in ED departments, intensive care, COVID wards. It's less clear in other areas like oncology, where clearly you're looking after a highly vulnerable group, respiratory wards, spinal units, you name it. I run no end of these high-risk environments, which in many ways, the only advantage is that I have significant capacity to actually move and flex my staff in my beds. And in residential care, you have no such capacity. You can't surge your staff easily. You can't close beds or cancel surgery. You can't do a whole lot of things about pivoting your work and your workforce. And I suspect, unlike some other countries in the world, we don't have access to a grey workforce. We don't have a significant number of people who are lowly paid and poorly and who want to work there. And there's very few of my friends whose children have an aspiration of working in residential care, particularly at a personal care type level. And that area has traditionally been filled by overseas recent immigrants, overseas backpacker type communities, recent arrivals. So once you lose that workforce, it becomes increasingly challenged. One of the things we noticed when acute hospitals started to pivot and support residential care and provide staff to residential care, all of my senior staff who came back said to me, Michael, I've never worked so hard in all my life. I cannot understand how these people manage such intense, heavy workload with personal care. And I think it gave a whole lot of clinical staff new and great respect for residential care workers who it's physical and high time-based work is very difficult.
Yeah, there's one other comment I think that is worthy here. We also have healthcare worker shortages, specifically in aged care facilities, and they are also paid less here. And in the context, of our studies on outbreaks, now we've done a couple of those. Having part-time workers, which is a symptom of having shortage of work staff, where you have people who are working, more shorter shifts. That was also a feature that both was predictive of influenza outbreaks as well as COVID outbreaks here. So it's a problem, having stable workforce and having people that are full-time are part of the solution, not just vaccination.
Just to add, I got a message that from one of our attendees at aged care workers in New South Wales do have to have flu vaccination as part of their employment. And I know, for example, in Queensland, my brother, who has a 95-year-old mother-in-law, was not allowed to come in as a visitor to a nursing home in southeast Queensland until he was vaccinated against flu. And we need to mandate that if we do those kind of mandates in particular settings, perhaps we should study that more closely to see what the pros and cons are. I mean, Michael's really presented very well on the pros and cons, but is there any scope for translational, practical, academic input to this, do you think, Stefan?
I think the exceptions are in medicine, when we talk about quality, we're trying to standardize everything, but the exceptions are often the lessons. And I love this example of a facility that has figured out how to make the mandate work. In the US, there are also such facilities. Usually these are the ones that are better off. They have endowments and other kinds of things that help them with keeping that workforce. But in messaging, in getting uptake of COVID vaccines, which you would think where we were devastated, we have over 30% of our mortality in this country has been from coronavirus. We still have facilities where COVID vaccine uptake has been problematic. And to nudge that, it is more than education. It's reaching the healthcare workers where they're at and talking to who they consider their health authorities. So when we gave Doctor Hour, for example, that was an effective strategy where they could get on a Zoom call and spend an hour with the doctor to answer their questions, and that kicked up acceptance by 15 to 20%. So with our usual flu vaccine, our vaccination acceptance among residents is around 85% or so in most years for the long stay residents. And for healthcare workers in hospitals, it's in the 90s, but in residential homes, it's typically in the 60s or 70s. It's quite low. This year with COVID, before we were doing those doctor hours, the COVID vaccine uptake was also in the 50 to 60% range, but we finished out the year with being better than 80. I don't know if we can get to 98%, which is where we'd like to be, but I think that is the approach is trying to figure out who their authority is, which might be the coworker next to them.
Michael, go.
Yeah, Victoria, as people are aware, used to have mandatory influenza vaccination. That was ceased last year amongst staff. And the reason it was ceased is because there was concern around staffing levels and availability. And it's very difficult to have these things running during an outbreak because you can't necessarily mandate your surge workforce to be vaccinated. So there are some practical problems, and there's some inconsistencies across the state. The line I'm pushing with the 15 odd facilities I'm on the board of is that this should be a strategic opportunity for us to advertise that we are actually supporting vaccination, which indeed will actually support our ability to pay staff higher rates and to remain full. Now, people are aware that in America, it's been very challenging to have full occupancy, and full occupancy has a dramatic effect on profitability, or at least even break even. And that's been a similar problem in Australia, where our average rates in residential care are less than 90% on average. And therefore, if you can fill your facility to close on 95+%, hopefully that will then allow you to actually pay people better and make the facilities more profitable, which in turn, so I'm seeing this as an opportunity, and I think that's the way it's got to be seen. And I agree with Stefan.
I'd like to go now to Stefan again, and you've done all these really large trials. I know you plan to try and do a head-to-head study, but that's very hard to do in academia and in industry land. Would you like to comment on the relative benefits of the enhanced vaccines against flu that are being offered, particularly in the US, but also in Europe and Australia?
Yeah, so what's available in the US is different than what's in Australia. I think you have the adjuvanted vaccine and not the high dose, although I think high dose was being offered for a season or two not too long ago. Sort of in the big picture of things, any enhanced vaccine is better than no enhanced vaccine, relatively speaking. And the relative added benefit against hospitalization, at least in aged homes, is, in the 6, 8, 10% ballpark for all-cause hospitalization. In the US, that is a cost benefit that is in the hundreds of dollars. In Australia, it might be less than that because care is less expensive. But I would wager to that it would also have a cost benefit there. We can't speak to whether high dose is better than the adjuvanted vaccine. And the reason for that is that they haven't been done head to head. These are different seasons, and anybody who researches flu will tell you, you don't know what's coming. And when you go back, unless you did it head to head, you really don't know how to compare them. That has to do in part with the population immunity, the viral load when you get inoculated. Clearly that's important with SARS-CoV-2 infection. Those are all sort of features that are hard to go back and reconcile in a way that it would be scientifically believable. I think what is fair to say is the enhanced vaccine, probably, so far as I can tell, no matter the format, likely will give an advantage downstream for improved protection for clinical outcomes. When we look at benefit to mortality, we actually haven't seen it in mortality, because I think most of the benefit mortality comes with the regular vaccine, but we see it for hospitalization outcomes, some of these expensive things that drive costs.
Yeah. While we're still with you there, Stefan, you showed in one of your really big studies that the benefit by way of relative prevention of cardiac events was twice that in respect of pneumonia admissions to hospital. So there's a big driver for flu vaccination, not just because of pneumonia and influenza and the like, but also myocardial infarction and chronic heart failure, atrial fibrillation. Is that coming out from all the studies? You presented the very nice summary stuff from Rainer. Is that
Yes. So Rainer did a wonderful job in putting it all together, and I think it's a theme that we've seen across multiple studies. Certainly in ours, we see this too. I think one of the challenges for the regulatory bodies with vaccines, what they consider as vaccine effectiveness is when you can demonstrate that the laboratory confirmed illness that the vaccine is protecting you against is prevented. They don't readily accept, like for a diabetic drug, which improves glucose control, can also reduce heart attacks. They accept that for diabetic drugs, but they're not quite there yet for vaccines in our country. nor is there an appetite, it seems, in much of the rest of the world. So I think one of the advantages of the pragmatic design is because we don't control, how they decide who to hospitalize, is that if you're asking the question and you get the same answer over and over again, at some point you have to say, well, that isn't just chance. There must be really something about the vaccines doing something beyond just preventing an influenza infection that you couldn't count because they aren't testing the way that you might like them to. But there are these other events that are just not occurring at the same rate. So for the high dose vaccine, I think our estimate for that is around 18% reduction in acute myocardial infarction. And that's relative to a standard dose vaccine where we already know that's in 15 to 45% range.
Yeah, I'm acutely conscious that we're all old white males with grey hair, but I don't have a bow tie. I'm jealous. Cost is really an issue that goes across all of our discussions, and being able to better look after older people as we would want to be looked after when we'll need it. I'd like to challenge Michael to see what's the best way forward to get the best bang for our dollars. Of course, we need more dollars, but the dollars we currently have, how can we better spend them?
Well, that's a really great question, because certainly when I was associated with the Victorian Aged Care Response Centre, we spent money like lolly water, and not the healthy sort. There is no doubt in my mind that we need to actually develop improved models of care. I think we've recognised that there were significant deficiencies in our models. Our general practice support to residential care is based on a fee-for-service model, and we're not going to change that, but we need to actually make it better. We need to have better support, better governance, better leadership, and that can be done cost effectively, and that needs to happen. We need to actually, in a society where we've got relatively little COVID, in every single adverse event regarding vaccination is picked apart like the chicken entrails. It's very difficult to support and encourage vaccination rates where the risk of COVID is very low, particularly amongst staff. So therefore, we really need to have strong social messaging and strong engagement from every sector. And I think what we haven't really seen, other than in the time of crisis, is clinicians working with politicians, working with unions and working with media to get really strong strategic intent and an altruistic view, which is all too rarely promulgated. I thought Stefan's talk was fantastic to refocus our attention on influenza and just how serious that is long term. And if half of what they say around long COVID is true, we've got a great developing problem should Australia lose its fortress front door and COVID become more problematic in Australia, which is inevitable in my mind if we don't actually support the world in vaccination. So I think we need a strong national view. We need a strong international supporting view. And I think probably clinicians need to be the leaders, because it's fairly clear that it's not going to come from the media or the politicians.
Stefan, do you want to add something? I'm happy to talk if you aren't.
Well, you haven't had a chance to give your side of an opinion here. Why don't you take a crack at it?
Well, I've got a couple of things I want to say. First of all, a lot of people have been asking whether the slides would be available. Some are, some aren't. It's for reasons of confidentiality. This is a special conference and not all slides can be shared. That's the first thing to say. We have a tremendous audience, over 200 people still. And one of them is Paul Van Binder, who you mentioned, Stefan, who did that great study in Canada and showed benefit of vaccination, and also showed of enhanced vaccination in elderly, but he also showed the importance of mandating healthcare worker vaccination and took it to the courts, and it's still 8 years later a mandatory approach in Canada that appears to be working. So I just wanted to make that point. To go to the issue of cost and my own talk and what's coming, I have to say that it was really covered very well by Paul Griffin, and I just focused in on one particular topic, which is using that Nanopatch. And the Nanopatch is being designed to become comparable in cost to needle and syringe. It isn't yet, but that's why you develop a product. You work out how to make it better and cheaper. And once we go through good manufacturing process and upscale to millions of doses being produced weekly, the costs will come down tremendously. But right now, it's an expensive product because it needs to be fully developed. So that's the answer to that question. Anything else? So that was in British Columbia where Paul Van Binder was working. As Ros Wilson said, I mentioned some personal example. I'm worried about my brother, he's in surgery right now. So, but Ros said, visiting her mother in aged care in Victoria, we have had mandatory approaches. I think we've covered that. I could go back to you, Michael. Is there anything on the questions or comments that you want to refer to? Have we covered off on all the topics that you've been particularly wanting to focus on? I've lost you there. I'll go back to Stefan.
Okay. I think there was an interesting question at the end there that says, given that we have little flu since March of 2020, should we rely more on social distancing and masks rather than vaccinations? To me, that is, this is not to take the question not so seriously, but in the US, if you look at what happens in vacation land like Florida and Texas and so forth, they have so much fatigue from social distancing and wearing masks that they're essentially have abandoned them. And with that, we are now starting to see stabilization of our dive in cases, even though it's summer. So I think we're going to have another wave. So the short answer to that comment was, I think it's great if that's what we could accomplish, but it's not likely something that the population will adhere to. And in aged homes, it's a special problem because that isolation, generates depression and other kinds of problems that contribute to health outcomes. So I think we have, really the right approach is to vaccinate so that we can have our social contacts the way we're accustomed to, and that'll generate a healthier population overall.
Well, it's a lovely note on which to end. Thanks to both of you, Stefan and Michael. It's been another great session. The next session will come after lunch, and it'll be chaired by Professor Margie Danchin. And we can all have a little bit of a break now. So thanks for your attention. Cheers, and see you.